Otolaryngologists were doing this for decades, probably for nearly 100 years, until the late 1950s, when gastroenterologists developed flexible esophagoscopy. At that point, esophageal strictures became the part of the became standard treatment for gastroenterologists. It wasn't until the last 2 decades that otolaryngologists became re-involved with the esophagus. A large part of what drove this was the fact that a lot of otolaryngology patients develop mid and high esophageal strictures as well as hypopharyngeal strictures due to the increasing use of radiation and radiation with chemotherapy to treat head and neck cancer. And this developed huge numbers of patients that needed help. Gastroenterologists in general are not comfortable with the dilation of hypopharyngeal or proximal esophageal strictures, so over time otolaryngologists became more and more involved. About 18 years ago, with the popularization of transnasal esophagoscopy, otolaryngologists became even more involved with esophagology in general, and specifically with the treatment of people with esophageal strictures. And so we began to do more of this, both in the operating room, as well as with patients under sedation, and as well as patients without sedation. A lot of these are in regular patients without pathology of the head and neck region that just have gastroesophageal reflux-induced strictures. But a lot of these are, once again, in patients that have undergone radiation and chemotherapy, and also people that have developed strictures of their neopharynx after laryngectomy. A lot of these individuals will also develop dysphagia due to strictures, and we can deal with these people very quickly and very easily.